All right, we're live on Facebook and we're recording. So, again, thanks everyone for tuning in. I've really been looking forward to this particular conversation presentation. I met our guest about 2 years ago almost. She was a featured presenter at a Parkinson's Day, I'll call it, here in Syracuse, New York. And we didn't get to spend much time together, but I loved everything about you. How you have such a huge heart. You're so much knowledge, and I'm so glad you're going to share today with us about medical marijuana. So please welcome Dr. Tony De Marcaida. Thank you very much for
Oh,
joining me.
well, thank you very much for thinking of me, Carl. I didn't think that you would remember me after 2 years hiatus, but that program that you did put together in Syracuse was phenomenal, and I do remember it well. Your crowd was dynamic, and you are a dynamic presenter yourself. So it was a lot of fun, and I enjoyed meeting your community.
Well, thank you. We had some people who brought us together. Brian Kalfas, and um, he was the main person I think who really helped me to get things together because I knew people who could attend and he knew people who could speak. Well, I guess I had one guest presenter myself, but it was just so great. I remember, and we won't talk about this today necessarily. Our focus is on medical marijuana, but your presentation on hallucinations and what's the other word? I'm still having a little bit of COVID brain fog.
It's
Delusions.
psychosis. Parkinson's
Yes.
psychosis is the
Thank you.
medical term for it.
Thank
Yes.
you. Thank you. It's so interesting. So, but I am interested in this here today, what you'll take us through. I've traveled a lot around the world. I have been very lucky to meet some wonderful neurologists and people from the medical community. And then a lot of people, unfortunately, have Parkinson's, but I'm lucky I got to meet them. And I'm sure, as you are many times in your practice, so inspired by some people, right, with their attitude and their looking forward. And I have met several people who use cannabis or marijuana of some type. I know we're talking medical marijuana, but I'm real curious to learn from you. So, it's an area I don't know much about, and I can't wait to learn. So, I'm going to turn it over to you. Thank you.
Yes, yes, and I appreciate the opportunity to have this conversation with you, Carl. And please, I didn't want this to be a lecture, although I have given presentations on the topic before. And the reason why I had to look into this myself is because it was legalized for Parkinson's disease a few years ago. And in different states, one by one, the states have legalized medical marijuana, and frequently, Parkinson's disease is one of the indications that would be included as the uh, diagnoses that can receive medical marijuana from the medical dispensaries. But the topic, when I have discussed it before, is really medical marijuana for Parkinson's disease. Is there science behind the politics? Because what happened from that point on is that I would receive a lot of questions from patients. Does it work? Does it not work? Should I try it? And of course, our people with Parkinson's disease, they run the whole range and the whole spectrum of being 40 years old to being 90 something years old. So, as a
Right.
physician, I wanted to make sure that we were very thoughtful and very accurate in our recommendations about medical marijuana. One of the first things that I want to express, Carl, is to remember that even if this is cannabis that has been around since 3000 BC, it is a substance. You have to treat it like medication if you're
Hmm.
going to try it. So that is the one thing that I want to share. Actually, as regards all naturopathic treatments. So people are more interested in nutraceuticals these days. That's herbal medications. We're going to consider medical marijuana, cannabis as an herbal. And all of these nutraceuticals, although people like to think of them, well, natural, it can't be harmful. Remember that it's still a substance, and
Mhm.
you have to treat it in the same way that you treat medications. So it was legalized in California in 1996. New York State, I'm thinking, was 2014 that your state was that came on board for medical marijuana.
Mhm.
There are now comprehensive medical marijuana programs all across the United States, 33 states, including DC. But it is a state by state approval of the use of medical marijuana.
Right.
So remember that although it may be legal in your state, federally, it is not legalized.
Mhm.
So all of these guidelines are on a state by state basis.
Okay.
So the conditions that have been approved for medical marijuana include cancer, cachexia, meaning wasting syndrome, where people lose their appetite regarding cancer. Vomiting is a common indication. Seizures, I think a lot of people have heard about epilepsy,
Mhm.
particularly in children, right? There's medical marijuana for that too. And of course, most important to us is Parkinson's disease.
Okay.
And if you let me keep talking, Carl, I will never stop. So you'd better interrupt me as we're going along.
Oh, okay. Well, one thing I did want to say is if anybody watching on Zoom or on Facebook have questions on Zoom, throw them in the chat box. If you're on Facebook, throw them in the comments. Interesting.
Yes.
Cannabinoids. A botanical form, most common form of recreational and medical. Okay.
Yeah. So the
If you don't mind,
cannabinoids is the umbrella term. So
right.
cannabinoids is the umbrella term for all the forms of cannabis.
Okay.
And when we talk about the street drug, marijuana, weed, Mary Jane, I don't know what the street names are these days. I'm not too savvy. But the street drug marijuana is a phytocannabinoid. So that is the natural form, where it's still the leaf form that is converted into the street drug.
Okay.
The plant, of course, is Cannabis sativa. That is where we derive marijuana, whether it's medical marijuana or the street drug marijuana. And the primary component of cannabis that is enhanced in the street drug is tetrahydrocannabinol. So people will ask about THC
Right.
as opposed to CBD, which is cannabidiol. So these are the two components of, well, one of 100 components of cannabis that have been extracted and enhanced in either the street drug or medical marijuana.
Okay.
So
I have a
that is
question.
phytocannabinoids, yes.
Question real quick. I want to make sure I don't forget this. Our friend Joel just wrote in the chat box, and I told him I was going to ask you about this last night. And I may be putting the cart before the horse here, but
That's okay.
can medical marijuana help with somebody who's living with ataxia?
With ataxia. So I don't think ataxia is one of the indications that have been approved for medical marijuana. But there are, and I will go into the medical basis of why cannabinoids in general have been helpful for movement disorders, potentially including ataxia in terms of coordination. But that can be twofold, though, Joel, because cannabinoids can also cause ataxia. And that's
Oh,
why it's that drunken kind of side effect that can happen when people use the street drug, right? It's sort of loosey goosey and
mm,
their balance is not impaired. They may be mentally foggy. So we really need to talk about how to carefully use cannabinoids for movement disorders, and I will go into that a little bit later. But
okay, great.
ataxia is not it's not a common condition to begin with,
Yeah.
Joel, and that's why it's challenging to get it into any roster of diagnoses that get approved for certain drugs. And I don't think it has made the roster of indications for medical marijuana unless you have
Okay.
it in New York.
Okay. Yeah, I don't think we do.
Yes, yes. Similarly with dystonia. So these are the movement disorders that we treat. as movement disorders neurologists. Dystonia is another movement disorder that is not as common as Parkinson's disease. So we are trying to get it on the list of indications for medical marijuana. Similarly with Huntington disease, so that's Korea.
Mm-hmm.
So yes, these rarer neurologic conditions may not get as much um, support sometimes for
Mm-hmm.
advocacy to get treatment options that are novel. But it's people like you, Carl, who make it happen. So when there is a patient
Well,
advocate, a community advocate who takes the lead, then sometimes we can make that happen. Mm.
well, I do what I can. I tell you, I don't know much about so many things. I was just this is off topic just for a minute because this is what I do. But in fact, I need to send you a copy of my book. I meant to do that, and I probably just forgot. But I put out a
Aw,
book last year. It's pretty big. It's
that's incredible.
really about Parkinson's disease management strategies. And I wasn't intending to use this platform here right now today to promote this. I mean, this is the
Mm.
Spanish version. I don't have an
Oh
English
my
version
gosh.
here now, but it's in two languages. So this is Spanish. We have it in English too. But I wrote this thing, and my point is sometimes I feel like I don't know anything. You know what I mean?
Oh,
Have you ever had that feeling? Like I'm starting all over again. It's like, what do I really know? But then
yes.
I have to just sit back and think, okay, wait a minute, let's just move forward. I know some stuff, but I'm learning from you today, and I'm grateful for this.
Oh, yes. Well, I think we all learn from each other and we have to
Mhm.
learn every day. I think that there
Yeah.
are things that we know a lot about. You certainly know a lot about, biomechanics of the body and how to make that work for you for various diseases. I know a lot about neurology and movement
Hmm.
disorders, but when I have conversations with my son about different things, it's like, okay, I know nothing about that and I am eager to learn.
Sure.
Yes. Yes. But
So
yes,
we
and
can
I
learn
think
from everybody, right?
that's
There isn't a
right.
person out there I can't learn from. So if we look forward, I can't help looking ahead just a little bit. Endocannabinoids.
Yes, yes. And I really didn't want to go too much. I love your platform, Carl, where it's really just a conversation.
Thank you.
But so I don't want to go too deeply into a
Okay.
presentation, but endocannabinoids refers to, and the only thing that's important to point out is we have cannabinoids in our own brain. So
Right.
cannabinoids, endocannabinoids, are the naturally occurring neurotransmitter or neurochemical in our own system, in our own bodies.
Right.
And that is what we have to tap into if we start thinking of using cannabinoids for medical indications. So endocannabinoids occurs naturally in our brains, in our immune system, and it is a neurotransmitter. And then synthetic cannabinoids now gets into the medications that have been formulated. And that has been around actually for many years, probably from the 1990s, 1980s, with Marinol, which was for chemotherapy-induced nausea, Sesamet. These are all cannabinoids, synthetic cannabinoids, pharmaceutical cannabinoids. And
Hmm.
then now we have the cannabinoid for epilepsy in children as well. So
Interesting.
phytocannabinoids is the plant, endocannabinoids is a neurotransmitter in our brain, synthetic cannabinoids are the medications that have been formulated by the pharmaceutical industry. And
Okay.
as I was saying, there are over 100 cannabinoids within cannabis plant. And THC and CBD are the ones that your audience needs to really know about.
Okay. All
Yeah.
right. I have a question from my dear friend Laura, who's in Texas. I'm sorry, Mexico, near Laredo, Texas. Though she is a lady who lives with Parkinson's, and her question is, what recommendation can you give to the Parkinson's community about the use of medical marijuana? For example, persons who have advanced Parkinson's and a lot of pain. Will it reduce pain or symptoms, or what might we expect if we use medical marijuana?
Yes, yes. And I think that that is really going to be the main conversation that we're going to have. And I will have a slide. So, Laura, and thank you for watching us all the way in Mexico and Laredo. But the main, um, the conversation that I have with my patients is that on the basis of what we know about medical marijuana, it appears to be safe for Parkinson's disease, including people who may have more advanced Parkinson's disease. But the problem is that systematic clinical trials have not been done. And that's why the topic of the title of my talk is, is there science behind the politics? And
Mm,
I'll tell you why I said that. Because later on, when we talk about what happened in research for cannabis in Parkinson's disease, and we'll talk about some of the smaller studies that have been done on cannabis for Parkinson's disease. But yes, it appears to be safe. But this is why I wanted to define for your community what THC is and what CBD is. So if you're going to be using it, you want to use a high CBD, low THC ratio of a preparation. If you can get it from a medical dispensary, that's going to be even better because then they really know, okay, it's a 3-to-1 ratio of CBD THC. And the reason why you want high CBD, low THC is because of this slide. So as I said earlier, THC or tetrahydrocannabinoid, cannabinoid is the cannabinoid that is most common in the street drug, and therefore THC is the component that causes that euphoria, that
mhm,
causes that sort of out of mind kind of experience that you can get from using street drug marijuana. So if it is high in THC, then you might have more of these side effects that you don't want in Parkinson's disease. You
mm,
can have more sedation on top of all of the medications for Parkinson's that make you sleepy. You're now taking medical marijuana with high THC, and now you're even sleepier. Now you're
mhm,
more confused. Now you're more unsteady. And that goes to Joel's question earlier. Unsteadiness or ataxia can be a side effect of marijuana if it's high in THC.
mhm.
So, and you know how that, 1980s, 1960s stoner kind of stereotype for
Remember.
long-term marijuana use, right? So it's like,
Mhm,
hey, and not focus and sort of all of that can be potential side effects of marijuana if it's high
yeah,
in THC.
okay,
And that's why you want to have more CBD, cannabidiol, high CBD, low THC. So the
okay.
cannabidiol mitigates those side effects, makes it less of that euphoria. So you're not going to get a high from your
Mhm,
medical marijuana.
mhm.
It's medicinal. It's
Right.
truly medicinal. The CBD component of it is what is closest to our own endocannabinoids. So this is not about getting high. This is about getting help for some of your symptoms.
Okay.
So
I'm
when
going off on a just a little tangent for a second.
go
You know, in
ahead.
my lifetime, of course, and as a career musician before I got into this many years ago, I never got into doing marijuana, but I was around it a lot, and you know, as always, guys are gals, whatever, sneaking off and taking a puff or whatever. But then, 5 years ago, this year in September, I went to Portland, Oregon, for the World Parkinson Congress, and a gentleman picked me up. We're driving around, and I couldn't believe it because the first thing I saw when I got downtown were all these, let's say, marijuana dispensaries. And my next stop on that trip, I had to go to Denver to teach. Same thing in Colorado.
Yep,
Said,
it's
wow,
Colorado.
it's here. It used to be like so forbidden, and now it's here. But it's different though too. It's not the THC; it's the high CBD. So times have changed. Interesting though.
Yes. But
And
I
by the way,
think though in
Laura
Colorado,
says thank you. I'm sorry.
oh, sorry, in Colorado though, Carl, they have both legal.
Oh, they do? Okay.
Yes. So some of those could be medical dispensaries, but some of those could be recreational
Oh, wow.
stores
Didn't know
for
that.
real marijuana.
Okay.
So be careful which one you go into.
You know, it's funny. Another thing too, a little tangent. I was there maybe 2 years ago. I'm not sure. On April 20th, 420. I don't even know what that means, but it was a big deal for people
Okay.
who smoke marijuana. So there's something about 420. I don't know what it is.
We have to look that up now. What is
Yeah.
April 20th?
So, somebody must know the 420 is like a thing. Okay, so let's keep going with this then.
Yeah, so what I wanted to point out now that you're talking about recreational marijuana. So in the past, the amount of THC that used to be in these formulations were low. So it used to be about 2% THC. Now they've gone up to 9.93% in some of the medical formulations of marijuana.
Okay.
And then CBD has gone down from 0.24% to 0.08%. So you really need to make sure that if you are trying to obtain medical marijuana from a dispensary, that you ask them for a high CBD, low THC ratio. And I still recommend that there is some THC in there, even if it's a low amount,
Hmm.
because THC is the one that's going to help with anxiety, which can be common in Parkinson's disease. It
Sure.
helps a little bit more with pain. It helps a little bit more with sleep. So
Oh,
I
okay.
want you to have some THC. And again, this is me making recommendations as though you were my patients, right?
Sure. Hmm.
Um, so I still want a little bit of THC, but really primarily CBD. So high CBD, low THC ratio, but not pure CBD if you have some of these other symptoms, because I
Okay.
still want you to get that um, benefit of a little bit of CBD. And by the way, the reason why I'm saying that I'm talking to you guys as though you were my patients is to give that disclosure that any medical information that you hear today is not necessarily medical information for you in particular, because
Sure.
you could have other medical conditions that I don't know about. So
Hmm.
you have to please run all of this information by your physician and always ask your own doctor about what is right for you.
Yes. Good point. Yes.
Yes, and then for the dispensaries, the street drug THC, also be careful. Naturally occurring cannabis used to only have a maximum THC of 10 to 15%. Now they have genetically modified cannabis so that the street drug cannabis has as much as 33%, double the amount of THC. So
Wow.
be very careful about what you
Hmm.
get out there because it could really whack you with the
Sure.
effect. Because natural cannabis is just 10 to 15%. Now they're genetically synthesizing a formulation of cannabis that has THC of up to 33%. So
Hmm.
just be careful about what you get from these dispensaries that are sprouting out all over your state.
Hmm. Okay. Interesting.
Yes. And now I was going to talk a little bit about, addiction and the fear that people have had about marijuana being a habit forming medication. So, there are 65 million Americans who used to use marijuana illicitly. Now that it has been um, legalized in a few states, then it's no longer illicit use in those states. But remember again, it may be legal in your state, but it's still illegal federally.
Hmm.
So, of the Americans who use it, 31% were 12 years old or older. So, there have been younger people who have also gotten a hold of marijuana. The most common form of the street drug is, of course, the smoked cannabis. It is
Mhm.
highly bioavailable. What that means is you smoke it and it's in your system very quickly. Because when you smoke anything, when you inhale anything, you are getting it into the lungs. The lungs is formed by all of these little sacs called alveoli, and all of those alveoli um, are vesselized, meaning they have blood vessels all around them. They have capillaries all around them. So from those alveoli, it's immediately absorbed into the bloodstream and immediately goes into your system. And
Interesting.
that's why any inhalational form is always much quicker in onset than the oral form, which has to go down the esophagus into the stomach, sit there for an hour or two, then go into the duodenum, then the jejunum. So it takes a longer time when it's GI tract,
Okay.
faster when something is smoked. So, as I already started to say, when we use the recreational drug, it's primarily for euphoria, for intoxication, it's for that relaxation, perceptual alteration. So, a little bit of mind, what is the word? Mind altering kind of effect.
Yeah, sure. Yeah. That
Yeah,
that
yeah.
works.
Yes. But, the side effects that can go along with that is what you'll have to watch out for.
Now,
You were,
I have a
go
quick
ahead.
question, and this may be covered in some of the next slides, but while I think of it, when we look at dopamine, let's say the lack of dopamine in a person living with Parkinson's, is it if you're smoking, let's say you're smoking, well, could be even a cigarette for some people, but marijuana, is there a dopamine rush that can happen or dopamine gets activated? And does that activation of dopamine lessen symptoms
So
potentially?
you are stealing my thunder, Carl. That is
Okay,
exactly the mechanism that I want to talk about. And
okay,
that's why
great.
in theory, uh, cannabinoids are really interesting in
Hmm.
terms of the potential for treating Parkinson's disease symptoms, um, even malignancies, cancers, immune system disorders. So it has all of this potential, exactly as you described, Carl. So you know a lot about a lot because you were describing the mechanism of action of cannabinoids in the brain. They are activators of dopamine. They're also co-activators of adrenaline. They're also co-activators of acetylcholine. So they're co-activators of a lot of these other neurotransmitters that are crucial for our system. So anyway, just to point out that recreational use and medical use tends to coincide. A lot of people who are comfortable using medical marijuana are comfortable because they have used recreational marijuana before, and that has been shown in the literature. Oh, I'm going backwards. But this is what I was referring to as regards your question. So the endocannabinoid system in the brain, and can you actually see my cursor?
Yes.
See
Hmm.
my cursor? Okay,
Yeah.
so this is the dopamine neuron right here.
All right.
And you can see that these are the cannabinoid receptors, particularly Cb1. So there are two receptors. The way that brain chemicals work is one brain cell is going to release the transmitter. The next brain cell has receptors or accepting sections of the cell that will receive that chemical. So it has to be released here, it's received here, and then the transmission of the signal goes down that nerve, goes into the next cell, goes into the muscle, and that's how the brain communicates with the body. So there
Okay.
is chemical communication, chemical signaling that occurs, as well as electric signaling that occurs. But this is all the way that the brain cells communicate with each other. And as regards dopamine, so dopamine being the main chemical for Parkinson's disease, involving Parkinson's disease, obviously, you see that we have found that there are Cb1, cannabinoid 1 receptors that
Okay.
co-activate that dopamine neuron. So
Hmm.
what it is that does is what is interesting to us. because it's possible that it can be a co-activator for some of the functions that are impaired in Parkinson's disease. It's also common in the gut. So these CB1 receptors are found primarily in the brain and in the gut. And
Okay.
I'm sure that your Parkinson community is very sophisticated too, but that brain gut connection, right? There's a lot of
Yes.
interest about that brain gut connection in Parkinson's disease. And then there's another receptor, the CB2 receptor, which is more for the immune system, which is more for the cellular functions. So malignancies, autoimmune diseases, inflammation, pain. So these are regarding the CB2 receptors, which are
Okay.
in the other parts of the body. So this is the endocannabinoid system that naturally occurs in our bodies, in our brain. And the interest is, what does marijuana do if you activate these cannabinoid receptors? It's like taking a medication that will activate that receptor that will then cascade that signal down to the body and potentially help with certain diseases. So that is the potential science that goes behind whether medical marijuana can be helpful for Parkinson's disease and
Okay.
other conditions.
I have a question. Can we go back to that previous slide real quick? And please forgive me. It could be COVID brain. I'm not always that focused all the time lately, but what is CB1, CB2? What does CB mean?
Cannabinoid.
Okay, I wonder. I just want to make sure. So, CB1 receptors are CNS brain, right?
Mm-hmm.
Okay, this is
Brain.
all connected and
Yes.
widely distributed in the gut. Yeah. So, is the vagus nerve anything that we want to be thinking about? Maybe like I've read and heard and a lot of research talking about how Parkinson's and Alzheimer's may live in the gut for 10, 15, 20 years before it gets here. And then it takes a little while to manifest a visible symptom.
That's exactly what I was referring to when I was talking about the brain gut connection.
Okay.
So there's a lot of interest in that. As and the reason why that this conversation had started is because you know how in Parkinson's disease, the microscopic abnormality that defines Parkinson is called a Lewy body, Lewy.
Mm-hmm.
And when you look at the dopamine neurons, you're going to find this microscopic protein that is very distinct called the Lewy body, which marks that that particular cell has the disease marker of Parkinson's disease.
Okay.
They found these Lewy bodies in the muscle of the intestines. So they have found these Lewy bodies in the gut
Wow.
when they did the colonoscopies in people years before they developed Parkinson's disease.
No
So
kidding.
these are people who eventually got Parkinson's disease. They had colonoscopies when they were 50. Now they're 70 and they have Parkinson's. And
Mm.
at 50 years old or 60 years old, they had Lewy bodies in their gut
Mm-hmm.
and they
Okay.
didn't have Parkinson's disease yet. So yes, it's all of that interest of whether it starts in the gut, goes up the vagus nerve, eventually gets into the basal ganglia, causes
Mm-hmm.
the symptoms of Parkinson's. And actually, don't forget about the nose too. So cranial nerve too, anosmia, loss of sense of smell. So that is the pathological mark. It's called the BRAC hypothesis, BRAAK
Mm-hmm.
hypothesis of how Parkinson's marches based on the pathology Lewy body that's found in all of these other places.
Interesting. Before you go on, I'm just going to mention we have a couple questions here, which maybe they're coming up, the answers, but just to keep in mind, can medical marijuana help with restless leg syndrome? And another question, what effect would medical marijuana have if someone has a DBS stimulator, if they've had implants? So just things to keep in mind. Thank you,
Yes,
Karen and
yes,
Joel, for those questions.
yes. And I have to admit, I didn't look at the restless leg literature That is something that I will have to search a little bit more on. I know that I have patients who have tried it. It tends to be helpful in pain. The medications for restless leg include dopaminergic medications. So again, this is something that I, as a medical researcher, should never do, but I am extrapolating information right now
Mhm.
and saying that potentially there might be some value of medical marijuana in restless legs, but there have been no studies. And
Yeah,
you will hear me saying that again and again. And the
sure.
reason why I keep saying that is because this is the limitation of what we can say about a lot of these naturopathic or nutraceutical formulations is without the scientific evidence, I can't say whether or not it works for restless legs. And please hear that. I am not saying that it works for restless legs. I am not saying that it works for Parkinson's disease. And the reason why I'm saying that is because we do not have good powered clinical trials that have shown us definitively whether or not marijuana works for any of these conditions. The ones
Okay.
that we have good clinical trials for are epilepsy,
Interesting.
neurology. So epilepsy, we actually have those clinical trials. That's why medical marijuana formulations are formally approved by the FDA for epilepsy in children particularly. But for
Interesting.
Parkinson's disease, we don't have that. For restless legs, we don't have that. But I do have to look at the literature as to see what they have for restless legs. And for DBS, any of these nutraceuticals will not be contraindicated in someone with DBS. So that is not going to be a factor that will affect the theoretical mechanism of action of
Okay.
cannabinoids for Parkinson's disease in someone with DBS. So yeah,
Makes
so
sense to
the
me. Yeah, I understand. Yep. Okay. And you just on another little tangent here, and you don't. I'm not asking you to speak about this, is but you do have a lot of experience with in the arena of epilepsy, right? Research and
with
working with people.
epilepsy.
Hmm.
Yes, as a neurologist, yes, I treat epilepsy, but that is not my subspecialty. So it's not my particular focus of
Oh,
interest
okay.
or
Okay.
research. Yes,
All
yes.
right. So,
But, but yeah,
let
so
me.
what I wanted to point out in this particular slide
Yeah.
is the reason why it's been so tricky to use cannabinoids or medical marijuana for treating diseases is because when I was talking about the CB1 and CB2 receptors being
Hmm.
co-activators for a lot of different transmitters, although that is a good thing, it's also a bad thing because now you have this receptor that is sitting in the cholinergic neuron, also in the adrenaline neuron, also in the dopamine neuron, also in the serotonin neuron. So
Wow.
then once you give a cannabinoid, all of those things are activated.
Yeah.
So then we have a problem. Houston, we have a problem. So
Yeah.
because now this chemical, the cannabinoid, is activating all of these different transmitters, active, activating all of these different functions. So how do you
Interesting.
focus it, right?
Yeah.
How do
Right.
you focus it just on that one thing that you want to treat? So
So,
that is the challenge.
are we after the treatment of dopamine activation? Is that our primary goal in
That is
Parkinson's?
what we want for Parkinson's disease.
Okay.
Yes.
So I can see where if all of them are activated, this could cause maybe some issues. Yeah.
Yes.
Very
So
interesting.
when we were talking about those Cb1 receptors just in the gut, look at all of the functions over here that cannabinoids can affect in just the gut. This is just the gut, not your immune system, not your brain, not your cellular humoral responses. So in the gut, it regulates food intake. It regulates visceral, which is the abdominal organ sensation, the sensory. It regulates GI motility, that's the movement, the contraction and uncontract this contraction and relaxation of the stomach muscles and the intestinal muscles. It regulates secretion of enzymes. It
Okay.
regulates intestinal inflammation. It regulates cell proliferation in the gut. So, this one cannabinoid can create a whole cascade of different effects.
Wow.
So,
Well, actually, so another thought I just had, I'm sorry I'm interrupting, but it just
no,
made me
please
think
do.
about constipation because it's so prominent and, well, in our society in general, at least in the Western world, but in the Parkinson's community, this is an issue. So, does this help with constipation? A cannabinoid?
So again,
You don't have research,
formal
probably,
studies have not been done, but
right?
in
Yeah,
theory, GI motility is helped
I
by
see.
is a function that cannabinoids in our system, the endocannabinoids, the natural cannabinoids, does
Hmm.
activate GI motility. So whether or not that translates into helping with constipation remains to be seen if we ever get studies. So but yes, so that's what I was saying. So then
Hmm.
these receptors are everywhere. So activating it for one reason can activate it for other reasons that we don't want.
Yeah,
And
sure.
because it's activating it for those other functions, then we're going to have unwanted adverse effects throughout the body.
Hmm.
And that is
Okay.
the challenge of using cannabinoids. And that's what we have to be careful about.
Okay.
So we're talking about all of the places. So this touches on where it is that it is affecting dopamine, right? So the Cb1 receptors are seen in the frontal cortex, the front of the brain, the basal ganglia, which is the main thing for Parkinson disease, the hippocampus, which is our memory and emotional part of the brain, and the cerebellum, which is the ataxia part of the brain.
Hmm.
So that's for Joel again. So it governs pleasure, that's the emotions from the hippocampus. It governs movement from the basal ganglia and frontal cortex. It governs learning and memory also from the hippocampus and potentially pain. So there is the Mesolimbic reward center. Remember how a lot of times, Carl, when you have those talks for Parkinson's disease, they talk about how dopamine agonists can cause compulsive gambling,
Oh, yes, and
compulsive
shopping and
shopping. Yep.
yeah. Hmm.
So
Hmm.
you've heard that said a lot. And the reason for that is that the dopamine, again, naturally occurring in our brains, is responsible for reinforcing these pleasurable activities. So it's actually the upper that causes us to want something more. So people who have a lot of dopamine get a high from gambling, get a high from shopping. It's a pleasurable sensation.
Yeah,
And that's the basis of addiction. So,
absolutely. Yeah, yeah.
right? So if it's giving you pleasure, then you want to do it more. So the challenge is that the endocannabinoids coexisting with dopamine, that's when we run into potential problems with addiction. So it is possible that cannabis use can result in abuse and, and dependence in people who have that tendency for addictive personalities. And then, of course, the cannabinoids in the cerebellum and the basal ganglia for motor tone, for coordination of movement. So, again, for Joel, remember THC will worsen coordination, so will worsen ataxia and clumsiness, but CBD potentially can help with spasticity and with coordinated movement. I saw you have a question in your mind, Carl.
Haha. Yeah, probably about 10 of them. Yeah, well, I was thinking that there's a lady I've met a lot of people around the world who had some type of addictive type of thing, gambling, shopping. There was one lady in particular in England who went on eBay and bid on 97 purses because she wanted to buy a purse. And she liked a lot of them. She won 79 bids, had to pay
Oh
for them.
boy. Oh
And of
no.
course, then her husband says, "Where did all the money go?"
Oh.
Well, it's I bought a bunch of purses because I think she sold them too on eBay. But the bottom line was when she went to see her neurologist and they did a Cinemat or levodopa, whatever she was taking, adjustment, immediately, almost immediately, that urge was gone to shop. And so, is it like the instant gratification, perhaps, of i- is that part of this, like instant gratification? So I'm
It's
going to
the
go shopping.
dopamine. Yes,
Hmm.
yes. So that's
Okay.
the dopamine function. And to have that opportunity to tell your audience, if you are experiencing compulsive, and define compulsive as something that you don't do normally and now you're doing excessively and it's not under your control. So that's pathologic gambling, pathologic shopping, compulsive gambling, compulsive shopping, compulsive sexual behavior, so
Hmm.
pornography or affairs, compulsive working on the in the garage. You know, sometimes men will tell me I am in my garage all night woodworking, you know, messing with the toaster oven,
The man
pulling it
cave.
apart, putting it together. It's a real problem. And know that that can be a side effect of your dopamine medication. Most commonly, dopamine agonists, meaning pramipexole or Mirapex, ropinirole or Requip, rotigotine or Nupro patch. These are the three dopamine agonists. But it can also occur with levodopa or Cinemet because that's dopaminergic too. So
Quick question, because I think if I don't ask this, I know some people have to be thinking this a little bit. So if you're living with Parkinson's, you're on a dopamine replacement of some type, and you're finding yourself, hypersexual or shopping, compulsive this, compulsive that. Does that mean your dosage is too low and your
no, too high,
is too high?
too much
Is
dopamine.
too much dopamine? Okay,
Yes.
I always wondered about that. I could have looked it up, but
Yes.
I'm glad I asked. Okay, too
Yeah. So
high.
it's too
So
much dopamine. And it could be that it's enough dopamine to keep you moving. Because, right, Parkinson's disease is a dopamine deficiency. So
sure.
you need the dopamine in order to function in terms of moving, controlling your tremor, walking well. So that could be just the right amount of dopamine for your movement,
Mm.
but it's causing the side effect of the compulsion,
But not good for your bank account.
which is not good.
Yeah,
And you
right.
absolutely have to tell your doctor. And
Yeah.
particularly, they will choose to take away the dopamine agonist if you're on a dopamine agonist, because
Okay.
that is the one that has been associated most commonly with these impulse control disorders.
Okay.
So they could compensate for coming off the dopamine agonist by increasing the levodopa or giving you another Parkinson medication to make up for the fact that they have to take out the agonist.
Okay. Yeah, I'm
All
glad I
right.
asked. Thanks for clarifying that. Okay.
Yes, yes, yes. And yes, and thanks for allowing me to really make sure that I am saying this the right way, because you're all going to be talking to your doctors and then I'm going to get
Yeah.
in trouble for, I heard Dr. De Marcaida say this. So remember, it might be just the right amount of dopamine for you for your motor function, but it's causing side effects.
Hmm.
So it still has to be adjusted. It still has to be changed.
Okay.
Okay. All right. So yeah. So then the endocannabinoids in the hippocampus and prefrontal cortex can. This is where cannabinoids can help with anxiety, can help with depression sometimes. So giving you that good feeling is because the endocannabinoids are in the hippocampus and prefrontal cortex. It's also in the hypothalamus, also in the spinal cord, which is where it can potentially modulate pain. So these are the endocannabinoids, remember. So these are our own cannabinoids in our brains that are influencing all of these functions. So in the spinal cord, the endocannabinoids modulates pain. In the hypothalamus, the endocannabinoids modulate our automatic functions, including food intake or hunger for food, which is why too much marijuana gives you the munchies. It's because of that hypothalamic function. So
Sure.
that's how the endocannabinoids have naturally occurring functions for us in the brain. And this is all of the nerd stuff of how it works. You know, it inhibits voltage-dependent calcium channel activation, uh, calcium channels, and activates potassium channels. And then there is the cascade of effect of suppressing excitatory neurotransmission. But this in particular, is interesting because one of the mechanisms of Parkinson's disease is what we call excitotoxicity. So, oxidative free radicals causing excitatory toxicity through glutamatergic function. So, there is this whole um, list of processes that are the hypotheses behind why dopamine cells die when people get Parkinson's disease. So, what this slide is talking about is that potentially, again, endocannabinoids, our own cannabinoids, can alter that excitotoxicity process that causes cell death, that can lead to conditions like Parkinson's disease. So, this is the whole cascade of proposed mechanisms that can potentially, the interest is whether it can have a good effect on neurodegeneration in Parkinson's disease or Alzheimer's or Huntington disease. Because in
Sure.
theory, the endocannabinoids have this particular function. So it's all very interesting. This is the science. This is why there is potential in looking into cannabinoids as treatment for Parkinson's disease. So, the proposed therapeutic potential in Parkinson's disease, the neurodegenerative condition that is the basis for the loss of dopamine and the loss of dopaminergic nerve cells, is associated with, as I said, excitotoxicity, oxidative stress, neuroinflammation. And all
Yeah.
of these are potentially things that can be altered or modified by endocannabinoids.
Hmm.
So there are certain cannabinoid agonists that have neuroprotective properties because they inhibit glutamatergic excitotoxicity, because they block excessive calcium influx, because they decrease inflammation. So it
Wow.
really is interesting that it has
Yeah, it
that
is.
potential.
It's all it's I was gonna say this earlier, but it keeps just getting more interesting and complicated though. There's so much to think about, right? I can't imagine being in make sure my volume's right. Yeah. Having to
Yes,
consider all these factors, and this is per person because everyone's different, right? Uniquely
yes,
affected by the disease and other health
yes.
issues, possibly. As we always say in the workshops we teach, people with Parkinson's are people too. It doesn't define them, and they could have other problems. So you have a lot of things to consider. Probably
And
with any type of administering any medication and dosages. Um, I think I have a question here from somebody. Let me
yes,
see
and
what.
that's why, again, thank you for reinforcing that. And that's why, whatever you heard here, you have to run it by your doctor because your situation is going to be unique. I'm just telling you the background. This is the
Right, right.
background for this, and but your own situation you have to discuss with your doctor.
Um,
So, oh, go
and
ahead.
I'm sorry to interrupt. Yeah, Karen. I think Karen's in Texas. We met. I think when I was in Killeen, Texas. Karen asks how to go about registering for medical marijuana. I'm just guessing you would talk to your doctor. Is that
Yeah,
how that works?
no. So
Oh, I'm
again,
sorry.
state by state. So
Okay.
depending on your state, you have to look for your state's medical marijuana program. So look
Oh,
online,
okay.
say Texas Medical Marijuana Program or Connecticut Medical Marijuana Program. It's going to list a list of providers. So not all
Okay.
doctors can prescribe medical marijuana. I cannot prescribe medical marijuana. I did not sign up for it.
Okay. Yeah.
So there are providers or physicians who have signed up to be a medical marijuana doctor.
I
So
gotcha.
they give you a prescription on the basis of your diagnosis. And if Parkinson's disease is one of the diagnoses listed in your state, then you're going to get that prescription. It's actually not a prescription, it's more like a certificate of need. And then you
Okay.
bring that to your medical dispensary
I see.
and you talk to the dispensary pharmacist and ask them, I have Parkinson's disease. I have this symptom and that symptom. I have sleep problems. I have restless leg. So tell them about your symptoms and they will recommend a specific formulation because there's a whole bunch of
Oh,
different formulations.
so interesting. Karen, thanks for
So
asking that question too, because it's funny. I know that not every doctor can prescribe it. They have to, there's only a few in my county who do out of hundreds of doctors. Yeah, that makes sense. So go to your state's registration site, I guess, right? Find out what it's all, how your state
yes.
works with it. Okay.
So at least go online, look for what your state's rules are, because
Mm-hmm.
each state is going to be different.
All
I'm
right.
just telling you in general, that's what most states are doing. You have a provider, you get a certificate of need, you bring it to the dispensary.
All right.
Yes.
Sounds
So
good.
as regards the questions that was asked earlier, so we're going to get, and I want to make sure that, oh, it's already 12. Um, I want to get into the actual clinical trial. So this is where we're talking about how it can help with the motor symptoms, right? So
Mm-hmm.
again, the endocannabinoid system in the basal ganglia, where it regulates release of dopamine. So this is now where it can potentially help with movement, or it can potentially help with dyskinesias. But did we see that? Did we actually see it in clinical trials? So this is really the crux of my talk, because the clinical research that is out there, when I did a full search of all of the human trials that have been done on medical marijuana, on cannabis, cannabinoids, THC, all of those search words, and Parkinson's disease, I only came up with a few studies.
Okay.
And these studies are tiny. Look at
Oh.
this: 7 patients,
Mm-hmm.
4 patients, 6 patients.
Mm-hmm.
So these are tiny, tiny, tiny studies.
Sure.
And the reason I'm pointing that out is because when it's a tiny study, we don't have the statistical power to actually show whether it even works.
Right.
So these are now all just what we call anecdotal evidence, meaning my cousin's wife's neighbor tried it and it worked.
Yeah,
So it's pretty
I
much that
understand.
sort of thing.
Right. I
These are
understand.
small studies.
Yeah, those are small samplings right there.
That's
Yeah.
right. But in these small studies, 2 patients reported benefits for their movement, 7 patients reported benefits in their depression, anxiety, and sleep. 4 patients reported improvement in REM sleep behavior. That's when you're sleeping and you're thrashing about or
Mm-hmm.
talking.
Mm-hmm.
6 patients um, with Parkinson's psychosis noted improvement in their psychosis. So these are now all of these little things that have been reported, but it's 6 patients, it's 4 patients, it's 7 patients. So this is the neighbor of my cousin Joe's wife's friend kind of thing, right? So now this is open label observational study in Israel. 22 patients were studied, and this is still small. 22 is small. We need hundreds of
Oh,
people in studies with a blinded placebo control in a randomized kind of design, clinical trial design, in order to prove that something works.
right.
So when we say this is open label, everybody's getting the cannabis and nobody's getting placebo. So how do you know that everyone is just wanting to be better and therefore they're better? You know,
Right. So I'm guessing is money an issue with doing these studies?
it's not money, Carl, and I want to get to that too. So
Okay,
now
sure.
these are all of these little studies, right? There's
Mm-hmm.
improvement in tremor. There's improvement in the UPDRS score. There's This one is a negative trial, meaning that double-blind, placebo-controlled. So now when they did the placebo-controlled one, there was no improvement,
Interesting.
right?
Hmm.
So all of these things were open label with no placebo. Now they did a double-blind, placebo-controlled, and there was no improvement.
Okay.
They felt better though. There was improvement in well-being and quality of life.
Hmm.
But there was
So
no
fascinating.
improvement in
Yeah.
their Parkinson's disease.
Okay.
Okay, so
Hmm.
this one, 7 patients, improvement in dyskinesias. And this one was also placebo-controlled, but it's 7 patients, that's too small. This one, another placebo-controlled one, 20 milligrams of synthetic cannabinoid, 8 patients. Oops. No effect on the motor symptoms, no effect on dyskinesias. So that's the problem. So these are all small studies, and I'm showing you all of these studies. Half of these were positive, meaning they had good results. The other half was negative, where they had no benefits. But
Okay.
these are all small studies. And I just want to say, so if you are going to try medical marijuana, try the vaporizers. So do the vaporizers because smoke cannabis, like I said, inhaled cannabis is better than a pill. A pill is harder to control. It's more valuable. If you're going to have side effects, it tends to be more prolonged. It's unpredictable when it's a pill. It has to go into the gut, has to go to first pass
Sure.
mechanism, go through the liver and all of that. The bioavailability of oral, of pill form cannabidiol is 6% versus about 30 to 40% for vape.
Oh,
So you're going
okay.
to get more if you vape it. The
Okay.
reason I don't like smoked is because now we're talking about all of the other toxins that are in smoke, like
Sure.
cigarettes,
Hmm.
right? Now
Right.
there are other 4,000 other chemicals that are going to be in that smoke cannabis, hydrocarbons, carbon monoxide, all of those toxic things that will cause inflammation of your lung,
Oh,
and you don't want that.
no.
COPD and cancer and all of that. It also
Hmm.
higher rates of stroke and heart attacks.
Wow.
So you don't
Okay.
want any of that stuff. So when you do the vaporizers, then you're heating the cannabis, you're able to inhale it at the same time you're not generating all of those toxins.
Okay. Wow. Interesting.
Skip through that. So
Yeah,
now
that.
this is the answer to your question, Carl.
Mhm.
Why are we not having any clinical trials? So 1854, cannabis was a medication in the US dispensatory. It was official, it was legitimate. For nearly 100 years, it was part of the American formulary. We could have medical cannabis as a medication in the 1800s. In
Okay.
the 1930s, a lot of fear was escalated. There was a lot of negative press about marijuana, high profile films talking about the dangers to society. So 1937, it got taxed. 1942, it was removed from the US dispensatory. It was stripped of any therapeutic legitimacy. By 1970, US Congress declared it no medical value, declared it a Schedule 1 prohibited drug in the same category as heroin, LSD, and quaaludes.
Wow.
Marijuana is a Schedule 1 drug at that level with no
No
medical
kidding.
value and high addictive potential. Furthermore, the other barrier to research is that, remember, it's still federally illegal. So
Right.
only the University of Mississippi is federally authorized to grow marijuana for medical research.
Wow.
In order to get medical marijuana for your research, you have to apply to the National Institute on Drug Abuse. And they don't want to support medical research saying that it's helpful. They
Hmm.
only want to say that it's a drug abuse problem because it's the
Wow.
National Institute on Drug Abuse. So
So
you have to
interesting.
get their permission. And then you need FDA approval. If you get the Drug Abuse National Institute approval, then you have to get FDA approval in order to do the trial. And then you have to go through your DEA. in order to say, I'm an investigator who wants to perform a study on marijuana. So now you're on the DEA watch list because
Oh
you
boy.
have marijuana in your lab.
This is an interesting, complicated spiral right
And
here.
that's why we're not doing the research. It's like,
Okay.
I'm not going to jump through all of these hoops and get on the DEA watch list and,
Yeah,
make it.
exactly.
So it's all of these. But
Hmm.
the problem is, though, that medical marijuana became approved for use in many states. And that's something that I am not happy about either. Because now it was propelled by public clamoring, approve this, approve this, approve this, rather than having been propelled by scientific research.
Right. Boy.
So what we're unhappy about is the Congress banned marijuana in the 1970s without doing the research showing that it was not as high an addictive drug as quaaludes and heroin. And they banned it at that time. And now it's legalizing it, again, without any scientific evidence for medical use.
Hmm.
So now it's the public clamoring that is driving having this um, treatment option available to patients without any guidance for medical providers and physicians. So now a lot of doctors are being asked by their patients, can I use marijuana? What the heck do I know about marijuana, right?
Hmm.
That's what
Hmm.
a lot of doctors will say. And don't even go there
Yeah.
because
Right.
there's
Right.
no guidance. And yet they're calling it medical marijuana, and therefore it's a medication. And yet we have no clinical trials to prove whether it works. How
I
is it,
had, yeah, I had
right?
no idea about this. So I'm
And that's
really,
and that's why I get so passionate about it. It's like you
mhm,
can see I'm
mhm.
getting all worked up about it.
No, I love that though. I had no idea the public clamoring might be the main reason that it's legalized in 33 states or whatever, right?
That's exactly
Yeah, I
right.
didn't know that. Oh,
Yeah.
very interesting.
And that's the reason why, if you think about all of the medications that we have, Cinemet, Mirapex, Nupro, the new ones, Norians,
Hmm.
Ongentys, how many years of clinical trials, how many hundreds of patients who took the drug and took
Right.
placebo, scientific statistical analysis of these results before that drug comes into market. Medical
Exactly.
marijuana skipped,
Oh,
skipped all that, bypassed all that,
yeah.
and now it's legal in 33 states without any of that rigorous scientific process. And
Right.
now
And
you'll understand why your doctor's upset when you ask about medical marijuana.
you know what though? I didn't know that. And that makes so much sense. And now with that understanding, it just helps me to understand better. With all the potential interactions of or side effects or
That's
whatever
right.
with, right, you just start smoking or whatever, you take it, vape it, and what's going to happen to the other medications you took? How are they going to assimilate? What's going to happen? So,
Exactly.
mhm,
So these are the quotes that I had in here, rich and anecdotal. Remember, anecdotes, small
excuse me.
studies, testimonies,
Hmm.
lacking in scientific validation. And yet states have permitted the voters, the people, rather than researchers following standard FDA protocols to endorse its medical use. And that's what I was saying. If a state wants to legalize marijuana, leave us out of it. Don't call it medical marijuana
Hmm.
because then medical marijuana, they're asking their doctor.
Right.
And unless you did the research like I did, how can your doctor give you guidance? There is no scientific evidence for it. So the medical,
Yeah.
legal, and political issues overshadowed the science and the medicine of marijuana use.
Yeah, and just going, I don't want to keep you too long because I know you're very busy, but just one more comment though. When you're talking about what it takes, the hoops you have to go through, including being on the DEA watch list to do a study, who would want to do that, right?
That's right. That's
Very,
right.
very interesting. Okay.
Yeah, and that's the reason why there isn't that much research going on. But we hope that that will change because we do need the clinical research.
Sure.
And, just to point out, people say that marijuana is not addictive. I just want to point out that the risk of addiction to marijuana is 9%. What that means in 1 in every 11 user is going to be addicted.
Okay.
9% addictive potential is 1 in every 11 people who use marijuana will get addicted. So although it's not as high as cigarettes, 32%, heroin, 23%, cocaine, 17%, alcohol, 15%. So it's not as high as the others, but it is still significant. So,
Sure.
just to bear that in mind when you want to dabble in marijuana, that it does have addictive potential. It's just not as high as the others. But yes,
Okay.
I have taken up a lot of your time too, Carl. So thank
Oh
you
no,
very much.
I'm free till 2 o'clock. Just kidding. No, I am, but no. Well, I sometimes wonder about addictive tendencies. Uh, and it's interesting to me, and I don't, I will, I promise I will not keep you much longer here. But when I look at people who have had addiction problems, who I know personally, they may go from one addiction to another addiction to another addiction. I am not a doctor, so I don't know this for sure, but it seems like that dopamine rush or that dopamine thing is let's get more. I mean, there's a book that came out a year and a half ago called The Molecule of More, and I can't remember the author's name, but it's all about dopamine. And why do we fall in love? And then after 6 months, a year and a half, we're not feeling that euphoria anymore. Well, because it's different than other things have to kick in, serotonin, oxytocin, whatever it is, for the more, let's say, mature type of love, longer lasting love. But when I look at the addictive tendencies, I've also noticed that people who do, they might get addicted to exercise, and that can give a dopamine activation. And then I know so many people who were addicts who are now like swimmers and bikers and runners, and they're doing great. They're not doing drugs anymore, and they're in great shape. Just all of this, the brain,
It's
all of this stuff is
fascinating.
so fascinating, so complex. This has
That's
been
right.
so enlightening. This is fantastic. I really appreciate you help joining me and teaching us.
Yes. Well, again, thank you for thinking of me, Carl, and more power to you. And God bless you for what you do for the community.
Oh, you
I
too.
think
Thank
that
you.
your podcast and all of your activities are really empowering. So thank you.
Well, thank you. This has been just checking here. No, no other questions, and uh, let's do it again sometime.
I would love to.
Thank you. Yeah. So, everybody who's watching, I really appreciate the great questions. I appreciate you tuning in. We're here to help you. So it ain't about me, it's about we. Together we can help each other and we can help other people. So, Dr. De Marcaida, thank you so much again. You were
Yes.
amazing.
Have a good day, everyone,
All
and
right.
God bless. Stay safe. Stay safe out there. Wear your masks. It's a
Yes,
public health issue. It is
there
not a
is.
political issue. It's not about red or blue. Wear your mask.
It's real. It's real and it's here. So,
It
yes.
is.
All right.
Yes. Take
Thank
care,
you.
Carl. Bye bye.
Thanks again so much. Have a fantastic day. Bye bye now.